your Director of Community Relations here at Your Life, Pensacola. Get everybody just a second or two to jump on. I told you this was going to start at 5:30, and I love to be prompt. So if you are missing this or missing portions of it, it will be recorded live, it'll save, and you can go back and rewatch it. So this is our quarterly presentation education piece that we bring to you in the community. And we are so excited today because we have special guests. But before I keep you in suspense with that, I'm going to go ahead and turn it over to...
Good evening, Tammy Robinson here, Executive Director of Your Life in Pensacola. We are so glad you're joining us this evening. As we can see, Susie already had several of them popping on. We so appreciate you, and we're hoping to bring some education your way and just some knowledge. I'm not going to give it away. You'll see here shortly. So I pass this on to introduce another special person.
Hi, I'm Fred Hardy. I'm a wellness specialist for Vitality Living, and I am here visiting the community of Your Life of Pensacola this week in support of their wellness department. And I'm very excited to be here, and I hope you learn a lot and enjoy the education tonight. I'm not going to give it away because I'm not sure what it is. So
we have so much fun. Oh my goodness. So make sure every morning about 10 you log on to the Your Life Pensacola Facebook page. You'll like it, and then Tammy and sometimes some of our other team will give you an update that we are, what are we?
Oh my gosh, we are 0, none, zippo signs and symptoms of the coronavirus at Your Life. We're not planning on letting any little bug in our building.
And that is the way that we plan on keeping it. So today, I won't keep you in any more suspense. We have two very special guests with us. We have Mr. Joe Kearney, who is the Executive Director and Physical Therapist for Stack Home Health. We also have Mr. Tommy Delamar, and he is the Patient Care Specialist with Stack Home Health as well. Today, they are going to be speaking on Walk Steady. It's a fall prevention education. It's for those of you that are dealing with your family members that are getting diagnoses with dementia, Lewy bodies, Parkinson's, Alzheimer's. You're trying to care for them. You don't know what all resources are, and you're scared, or maybe they have fallen. And today we're going to have the education piece on how to help you. Mr. Joe?
Well, thank you very much. I just want to say first how much we appreciate Your Life. It's a beautiful facility out here. First time I've been here. And just to have the opportunity to come out and talk to our community at large about one of the things that everybody has to deal with at some point in time, and is one of the leading causes of hospitalization, and that is falls. I'm not going to throw a lot of statistics out here because everybody does that, but I will say this. Sometimes we don't really differentiate what a fall is. And I'll ask people and say, have you had any falls lately? When I was a physical therapist doing home care, and I still do that on the weekends. But out there in the community, you're doing home care and you're asking, had any falls? And people will say, no, I haven't had any falls. I'm doing okay. And you watch them back up to a chair. They lose their balance. They kind of stumble and then fall into the chair and say, whew, I almost had a fall. Well, actually, you did have a fall. You went from a higher position to a lower position unintentionally. And so technically that was a fall. It was a fall without injury. And when that fall occurs on the floor or hard surface, that's when we have a problem. So we want to identify the fact that those falls are occurring, and that is one of the leading causes, one of the leading indicators for future falls. If you've had a fall or had these near falls like this, that is one of the leading ones as far as unsteady gait and having a history of in the past or currently of having falls. Now, 1 out of every 3 adults age 65 or older, according to the CDC, is going to experience falls. So when we have those, they're very serious, and 90% of hip fractures are caused by falls. And it goes without saying, nobody wants to have a hip fracture. We live in a time where our orthopedic surgeons do a great job of getting people back on their feet. But to avoid that fracture, to avoid that injury is the goal. We do not want to have that type of injury. The top causes that we run into are gait abnormality. When you start seeing people who have a shuffling gait, they're unsteady on their feet, they've got weakness, you might see tight hamstrings, you're starting to see people kind of shorten their steps, maybe widen their base of support, arms are starting to be abducted from the sides, you start to see things change in the gait, maybe with a head turn, you see they lose their balance. So you start to see these little subtle signs, or maybe not so subtle signs, of unsteady gait.
Mr. Joe, can you please explain exactly what gait means for those that
Yes,
may
I'm
not
sorry.
recognize
When we're
that
talking
term?
about gait, we're just talking about walking, unsteady walking. Yeah, we tend to use terms that sometimes we forget are not very common, but we're talking about gait. We're just talking about walking. So I'll try to make sure I use those terms. When you start seeing unsteadiness with walking, that's when you right away you need to identify that, let your physician know, and that's where a physical therapist would be able to intervene and look at some things like stretching and all that. We'll get into those things, but that would be a good time to have an intervention. Blood pressure fluctuations. Now we see this, they'll call it, I'll give it a fancy word, they'll say it's orthostatic hypotension. All that means is when you stand up, the blood pressure goes down. And so why does that happen? It can be several things. It could be some medications that need to be adjusted as time goes by. Sometimes medications are stronger to our bodies and they need to be adjusted and lessened. That's up to the physician to decide. But cardiac arrhythmias, people can have an arrhythmia that causes the blood pressure to fluctuate, and also dehydration. Some of the medications we're taking when we get older are to keep the blood pressure down, and they have diuretics in them. If that diuretic is too strong, that can cause a fluctuation in blood pressure.
Mr. Joe,
Yep.
has it been proven, because I've only heard, that falls are the number one reason for death over 65?
That's, the CDC says that that's one of the leading causes of death, because once you've had a fall, usually it's going to have it's going to cause this cascading effect. And even though they can repair and do a lot of things right now orthopedically, once you start having falls and once you have those incidences like that, it usually leads into, if you don't intervene quickly, and if you intervene quickly, that's the thing, but if you don't, usually what you'll see is a cascading effect. You'll see a decrease in activity, of fear to get out and be as active. When you see activity going down, then you start seeing mobility going down. When mobility goes down and people are more stationary, they're more inclined to have all kinds of other problems like congestive heart failure, exacerbation of that, where it gets worse, or maybe pneumonia, all kind of other things that go along with that, and future falls because you're unsteady. Also, depression plays into that. When you're not mobilizing like you were before, you start isolating yourself, and you start seeing the fact that depression takes over, and it just becomes a tumbling effect on its own. You start becoming more and more isolated, less activity, and that has a problem.
I want to encourage everyone that is with us right now, please, there is a space to type in your questions. Kim, who is our engagement director, is doing this recording. So type in your questions and she will ask them to Mr. Joe and he'll answer them for you.
Joe, I have a question real quick.
Absolutely.
So let's say somebody's watching on this video right now and they've got someone at home with them, that they're starting to notice they're having some gait issues, some weakness. Do they have to physically get a hold of the doctor, have that appointment, or can they just call you guys directly and you take care of that process in order to evaluate? Kind of explain how that works if you don't care.
Well, that's a good question. You do have to call your physician to get an order for home care. If you're asking for home care to come out to the home. Now, the reason you would have home care to come out to the home is because it's becoming difficult to get to the physician, and home care is more appropriate for this individual, because getting out, getting into a car, getting dressed, going out, whether it's incontinence issues that you're dealing with, all these other things come into play. It's just difficult to go to an outpatient clinic. So the home environment is really the best in that situation. Also, it's best because you're going to be able to train in the situation you live in. So you call your physician, and they can go ahead and get orders for home care. We'll need a face-to-face.
I have to break in for a second. A lot of our families are confused between home care
Okay.
versus home health, and which is private pay and which is Medicare. Can you speak to that?
Sure. So we're not a sitter service. Home health is skilled services. That means there's nurses involved, there's physical therapists, occupational therapists, speech therapists. Whatever your need, we've had a social worker, whatever the need of that individual is, that's what we're trying to identify. What's the problem? How can we solve it? Working in collaboration with the physician. You've got a team of people trying to work out what do we need to do to solve this problem. Maybe all you need is nursing because it's a nursing issue. But back to that question, how do you get home health, or how do you get the help you need? If you're appropriate for home health, then you'll call that physician and get an order, and they'll start the process. A nurse will come out to your home, or a physical therapist, depending on what the physician thinks you need. Now, one thing that comes in really handy is you've got nurse practitioner groups in our area, and we happen to work with Beacon Medical. They do a great job, but there's nurse practitioner groups, and they come in really handy because a nurse practitioner can come to your home. They can write orders, and it can prevent you having to leave your home. And so that is a nice thing to have when getting out of the home is difficult. They come right to the home and take care of things, especially urinary tract infections, which start rising when you have decreased mobility. You start seeing a lot of things where you want to be able to talk to a doctor and get an order quickly, and the nurse practitioners can be right there. So that's another venue to look at if your physician is okay with that. I'm not trying to push that, but I'm just saying that's a great thing, and we collaborate with nurse practitioner groups all the time, and it's very helpful.
So that is an excellent point. I want you to speak though, so if they do use someone like Beacon or Pulse Medical, would they, let's say they were seeing Dr. XYZ, would they forego Dr. XYZ and then that Pulse or Beacon Medical nurse practitioner group become their physician?
Right, that's one of the things that people are very fearful of, and I'll tell you my thoughts on that right away. For some physicians, they're even scared. Oh, I'll lose my patient if they go and see a nurse practitioner. In this day and age, a physician is more likely to lose their patient if they don't use a nurse practitioner group, because when you start going to the hospital a lot, hospitals now are saying, hey, this is becoming a chronic rehospitalization issue, then they're going to look at tracking you down a different venue, a different way. Maybe it's hospice or something alternative like that, whereas your nurse practitioner, your home health, they're really looking to identify, saying, hey, how can we intervene and keep you active and at your highest level in your home? So the nurse practitioner group works and is covered by Medicare. They go into a different part of your insurance, so it's not an issue there. It doesn't conflict with the physician or your home health. And really is a nice thing to have if you're homebound and can't get out on a regular basis to see your physician. So it depends on some physicians, but most of them now are really coming around to the idea. It's really nice, and they're working in collaboration with these groups, these nurse practitioners, because these patients are not normally coming to see them in ways that's very difficult. And especially when we've got going on right now with the pandemic, getting to the doctor and being congregated in a room, we're all wearing masks like we're doing right now. And it's really a difficult situation for someone who's at high risk for infection to do that.
So before we get on into the demonstration, which we're fixing to, I know one of the number one questions on your mind is, does insurance cover home health in the home?
Absolutely. Whether it's commercial insurance or whether it's Medicare, home health care is covered. Medicare covers 100%. A lot of your insurance that we deal with now, you can check with them though. Everybody has a different plan. Do not have copay with it, but they limit the number of visits, and then they will give more visits based on need. So we have to just make sure that we're demonstrating that what we're doing is effective and that the outcome is going to be productive, so there's value in their investment into taking care of you. And I don't have a problem with that. That's what it should be. So that's something that is not a problem with with Medicare. It's 100% payment, but it's the same thing. They all want to make sure that what we're doing is helpful and productive, and they're going to be a good outcome. Now, with regards to falls, if we can move over to there, there's 3 primary systems that you have to utilize for balance, and everybody does. It's the vestibular, your visual, your eyes, your eyesight, your inner ear, we call it vestibular. So I'm going to keep it real simple. Your eyes, your ears, your balance inside your inner ear, and your somatosensory, which just means the effects of gravity on your joints, on the bones, the muscles, the joints, that we can feel gravity. So if I close my eyes, I eliminate sight. And I'm depending on my inner ear with the fluid in there to tell me where I am in space. And I'm also depending on my feet with sensation to tell me where I am with gravity pulling down through my joints and give me a sense of where am I if my eyes are closed. And if that's all working together, my eyes can be closed and I can maintain good balance. If not, that's one of the things therapists test. They'll have you put your feet together, they have you close your eyes and stand with your arms folded or with your arms at your side, and have you close your eyes and see. Do you start moving? Do you start swaying? They might put you on a pad that's kind of squishy. And then you don't know where your feet are in space, so you really depend on your inner ears to tell you where you are, and they'll do that. And if that's a problem, they can isolate down where is your particular problem, and then really focus on that problem that is an issue for you. But as we get older, all three of these things will be difficult. So I'm going to go through a few of these things one by one. And we're going to start with one of the primary things that we see, which are medications. I had a patient who was taking Tylenol in the evenings, and they would have all kind of problems with balance and just dizziness and some other things like that, just kind of just lethargy and all that. They said, all I'm taking is Tylenol. But they were taking Tylenol PM. And in Tylenol PM, there is Benadryl. And they didn't realize they were taking a medication that maybe for you and me would make us just a little tired and we'd go to sleep easier, but for this individual, it caused them a lot of problems. So we really need to look closely at what medications are being taken. That's where your healthcare provider takes a look at these and says, hey, if you're having some trouble with dizziness and balance and all that, they look to see what medications are you taking. Are any of these causing a problem? If you're having dizziness or lightheadedness when you go to stand or sit, they're going to look at blood pressure. They're going to do a blood pressure check on you and see if any of those things need to be adjusted. It may be just a medication issue. Maybe it's atrial fibrillation. They need to look at that. But these are things that a physician needs to look at, and it's related to medication. Even the inner ear with vertigo and things like that, they might put you on a medication like Anavert or something. But they need to assess that situation and determine, with physical therapy help, is it medication that needs to be adjusted? And so that's one of the things we look at first. When we go into assess, we look at medications. And so as a caregiver, always look at the medication. I know most people do. Look at the medications they're taking and say, hey, is dehydration a problem? Are they keeping enough fluid in them? Because, they take a diuretic and it's causing a lot of this. And what I've noticed, they get lightheaded when they go to stand up. They get lightheaded for a minute, and then they kind of have to sit back down. Hey, let's check that blood pressure sitting down before they get up. Let's check it when they stand. And if that's a problem, that's something to report to the physician. Now they can really help narrow that down. Physical activity. As we reduce the physical activity we're doing as we get older, we tend to be a little less active. You have arthritis that can affect how you feel, joint pain. You get a little bit unsteady, but the more inactive you become, for whatever reason your activity becomes restricted, you'll start to see that person will start having more and more difficulty getting around. Because the old saying, if you use it, don't use it, you lose it. That is absolutely true. And one of the things we start losing is muscle mass. And that happens, especially for males and females in mid-40s. We start the process, or sooner, depending on our activity level. You start losing muscle mass, and that becomes an ongoing thing that can cause a lot of problems. When you lose muscle mass, it'll cause instability, and then you'll start seeing flexibility problems as you try to compensate for that loss of muscle mass. You'll start seeing shortening of joints because people are you'll start to see tendons getting a lot shorter. You'll have flexion of the hips. You see hip flexure problems in the knees and all that. And so as we start seeing these problems going on, one of the things the therapist will do intervene is start a stretching flexibility program. We want to keep you flexible, want to maintain a full range of motion, and get that activity level up. One of the best things you can do is walk. We were created to walk. That's how we're created, and the good Lord made us that way. So if you have that ability and you're not limited by something, you want to be up, and if possible, if you're not, have some other situation where you cannot ambulate, if you have the ability to walk still, you want to maintain it, so you want to get on a regimen of daily walking. One of the worst things we can do is sit sedentary for extended periods of time. So one of the things we'll tell patients, they come out of the hospital and they're trying to get their legs back under them, is, hey, don't sit for more than an hour. Pretend from 8 to 5, as your working day job is every hour, get up and take a walk around the house. And if it's just 5 minutes, if you do that, 5-minute walk 8 times, that's 40 minutes that you've walked that day. So,
Mr. Joe, I have a question.
uh-huh.
So how would your therapist, what verbiage do they use to communicate with a more, moderate dementia patient for y'all, resident for us,
Right.
that may not just get up and walk? How does your therapist address them verbally?
Sure. Well, every situation's unique. When I went into a home, the first thing I always did was I assessed the home. It told me a lot about the person. When I walked in the door, I looked at the home. I looked how things were laid out. I also just looked at the little things to see, hey, look, the groceries aren't put up. They're still sitting out. That tells me they get really fatigued just doing the little things. So you're looking for all these little things that are clues to where they're having difficulty. Now, the beginning of dementia is setting in. You want to kind of get a feel for where this individual, how do you motivate somebody? Because to motivate someone, you're really trying to get them to have a vision of where they can be, and then help them have that idea. How are we going to, and then show them a pathway, how they can get there. But when you're doing dementia, it's not the same anymore. So what it really starts becoming about is developing a relationship. And that's one thing caregivers, and I feel sorry because a prophet in his own home, that people have no respect for. If you're the caregiver, people tend to give you a hard time because you're the one saying, hey, it's time to get up, it's time to get dressed, it's time. You're trying to keep them on a routine. The best thing you can do is have a routine, but the caregiver is the one that really catches it. Whereas a home care group can come in, this person they don't know, here's this young lady or a young guy or whatever, or in my case, an old guy. They come in, they don't know them, they develop a relationship, and hey, it's like a friend coming to visit. We're much more able to say, hey, let's take a walk. Hey, let's do this. And if they still have that desire to be pleasing to other people and get along, then they're usually going to do that. But it's all about developing that relationship. That's why an environment like we're in right now, everything about the layout of this place was designed to create that type of an atmosphere. A home environment is very beautiful, very comforting, very relaxing, so that relationships could be developed and people would be able to work with people. Very settling, very calm, but very beautiful. And so those things all play in hand. If you're in an environment that's very disruptive and you come in as a therapist and you're just in a hurry and you tell somebody how things are going to be, they will shut down on you really quick. So the big thing is I wouldn't be talking loud like I am now. I would have to bring it down a few decibels unless they have a hearing problem, and talk slow and try to relate to an issue, and usually start hearing some stories and say, well, that's interesting, and as you develop that little connection, let's take a walk, I want to hear about that. And then you lead into, while we're walking, I want to hear your stories about your life or whatever.
I am so excited too that we could have staff join us tonight, because we do have a couple of home health agencies that do come in here, but the beautiful thing is they do provide the same staff. They have that continuity of same people coming in. And we have all stages of dementia, Alzheimer's, Lewy bodies, Parkinson's, and even our very moderate to more advanced. Your team does a phenomenal job in keeping them cued, interacting, and to participate and do what they need to do. Thank you.
Well, I appreciate you saying that. We've been very blessed to have the opportunity to keep the staff together. I think that's one of the keys. And one of the key things to the integrity of any organization is maintaining good staff, good people. And so when they go in the home, they've got to be able to be, if you have different people, one of the key things, it'll tell you right there, if I know a patient and walk in the home, if I say, how are you doing today? Just by how they answer me, I know, something's wrong. If I don't know that person, I'm going on just what they're telling me, because I don't know. So that is a great point, having the continuity of staff, and then we make sure we have people who are designated so that you don't get this turnover. And that's true. Any organization that does home care or health care, that's what their desire to do is. And that's one thing we've been blessed with lately, is we don't do that.
What are some techniques that y'all use in different forms of, like a walker or different things like
Sure.
that?
Well, one of the things, Tommy, if you don't mind, if you could sit right here. One of the things the therapist is going to do, they're going to watch from the minute we get in the house. We're watching to see how people move around, usually they're gonna come answer the door. If not, they're the ones sitting in the chair and we're gonna be taken to that person. But they're the ones that answer the door. We're gonna watch right away how they open the door, how they back up. Whoa, and they're kind of careful and they're reaching. Are they holding on to furniture as they go? Walking, touching things. When they go to sit down, do they just fall into the chair? So we're gonna assess all of that. We're gonna look at the home environment, make sure there's good, clear pathways. One of the most important things in a home is to have good lighting, good, clear pathways, a good surface. You don't want throw rugs that can slip and slide, and it's really rough if there's a lot of transition between carpet and brick and this and that and wood. There's a transition, give you a little trouble. But we're not going to go in there and change people's homes. What we can do is make instruction to make that environment better. Maybe put down tape so that transition is not as difficult, or it highlights a color there so they can see, oh, that's where it changes. But we're going to walk in, we're looking at the environment. We're not going to talk about that first. First thing we're going to do is look and say, and ask about, are you diabetic? Do you have any numbness in your feet? Things like that. Because if you've got numbness in your feet, that's going to be one of the problems with your balance. You've lost the one we talked about, somatosensory. That sensation that we talked about is one of the three. I can't feel the ground, so I really have to use my eyesight because that's gone. So I use eyesight and my inner ear. And if my inner ear is giving me any trouble at all, now I'm just bifocals, and bifocals can really make it difficult because you're seeing one thing here, but you look down and your depth perception is thrown off. So we're looking to see, do they wear glasses, what kind of clothing, and then but the first thing a therapist is going to look down is what kind of footwear. And Tommy's got some good footwear. He's wearing what you'll see, it's a non-skid surface, it's wide, it's flat, doesn't have a heel on it. So that's an ideal, and it's good fitting. He's got a good fit. It's not a shoe that's too big for him, that's slipping or sliding around. That could be a problem. But it's a good fitting shoe with a good surface and non-skid. So that's an ideal situation. Most of the time we go in the home, they're going to be wearing some type of scuff. They might be barefoot or in socks. And so we try to change that right away. And let's get some footwear that's going to make things better. And also, I'll tell you another advantage to wearing good footwear, something with an arch support. If you're having a lot of foot pain, and you're walking on hard surfaces, almost always that's going to be relieved if you have them wear something, a tennis shoe with a good arch support all the time during the day. Within about 4 to 6 weeks, you'll see a lot of that pain dissipate.
Wow.
It's because when the arch is falling, it's causing pain, so you get a real problem in the bottom of the foot. We won't go there, but that's something that's very important. So we're looking at that. We're looking at the lighting. The main, especially when you're looking at lighting, hallways tend to be very dark. You get a narrow hallway, it can be dark. We want to look at lighting at night when you get up to go to the bathroom. Do you have a little safety lights so that you can sit up on the side of the bed, wait a minute, you got some safety lights you can see, get your lights on. Because if you're losing any of those three things you're dependent on, visual becomes more important as we get older for our balance. And if we're dependent on that, we need good lighting so that we can see.
That's a thing I've never even thought about. Would you recommend any night lights or keeping a bathroom light on at night?
Absolutely.
I never even thought about that.
Yeah, we always recommend any little night lights that you can plug into the wall that come on when it gets dark. It won't keep you awake, but so when you come up, you can get up inside bed, you can see. And then the bathroom, make sure it's well lit, maybe crack the door. But have it so that when you sit there on the side of the bed, you're waiting a few minutes before you get up, you orient yourself, you know where you are. If you use an assistive device, you got it right there. That's the key thing, is having good lighting.
I guess also, not just working with the patient, what I'm hearing, if I'm not miscorrected, you would really need to train the caregiver as well to help work with these processes. Is that what I'm hearing?
Absolutely, especially if you've got somebody who is an early onset dementia. Now, if it's early onset dementia, we have some things we do. We have a Memory 360 program that can help with that we're pretty excited about. That staff is pretty exclusive on that. But the overall thing is, when you're working with someone with dementia, you're working primarily with the caregivers, and you're trying to develop a routine. Just like when we're younger in life, when we're younger, it's the same when we get older, a routine. And I think it's true all through life. A routine is a very important aspect of success. You should have so they're all breaking routine once in a while, but a routine will really help. And so we try to get families into a routine and to develop a household that is as safe as can possibly be. Because falls are going to occur, but we want to reduce the risk for those things happening. So if we can reduce that margin
30 or 40%.
on the outset, that's a big difference in a community. So that's one of the key things we look at is footwear, lighting. We look at the assistive device that they're using. And we're watching them walk, and I talked about all the different balance issues, and we try to look and see, is it somatosensory, is it somatosensory, is it musculoskeletal problems going on, is it diabetes is affecting their ability to do sensation and all that? Is it the vestibular, is it the eyesight? And then we try to target and see where it is, and then we work on those key things by isolating them with particular exercises. And that goes back into physical activity. We try to get people on a regular routine of walking, which is the best thing, and then an exercise routine that involves some flexibility and specific strengthening. And I personally like strengthening exercises to be done in standing while you're working on good posture, because it carries right over into your ability to walk safely. So that is one of the key things we like to do, is get people on their feet for exercise if at all possible.
So poor Tommy has got a vestibular issue going on, and that's your inner ear, okay? So poor Tommy is stuck over there with vestibular. What would be the possibility, Joe, that would cause vertigo, that could cause issues? Is that a strong possibility?
Right. We talked about this a little bit. That was we can go to that a little more in depth. But the inner ear problems that people will run into, it can be viral that can cause it. It can be medication that causes it. It can be positional, and that's one, when it's positional, something that occurs in the inner ear. It starts triggering those little hairs to activate, and so it becomes very disorienting. And that's something that therapy has some specific exercises. They're called accommodation exercises. There's also some positional exercises that can help try to clear that situation. But one of the things they'll do is, if the physician identifies that maybe, this is one that Anavert would work for, as I mentioned earlier, that can clear it up. Or maybe it's a medication issue to begin with, we need to cut back on. Maybe it's a blood pressure issue, maybe it's a cardiac issue. Or maybe it is one that positional vertigo, it's a situation going on that we can work with some very specific exercises that will help diminish that. And so that we don't have room for that here, but it involves laying on a certain side and back and forth, and it really helps to mitigate that problem. And you'll see usually in 3 to 4 weeks a significant change in that. Some, if it's clearing a canal, that can happen very quickly. I mean, it can be an hour later, you can see significant improvement. But for the most part, when you start to have these little problems with the inner ear, a lot of it has to do more with the inner ear in conjunction with your eyes. So when you turn your head and how they function together. Excuse me.
Bless you.
It's hard to rebreathe in this mask and talk. We're talking about, let's see,
Where were we on?
We were ending up with vestibular.
yeah, on the, how the eyes interact. So with the vestibular, I'm sorry. So that's an issue that a therapist looks at, because it'll affect your vision, because your head, as it turns, we don't think anything about our eyes adjusting. We want to look left, right, look all over. But what's really going on is a calculation is going on in the brain. So CVAs can have an effect on this. So stroke can have an effect on this. Your ability to calculate, the inner ear, actually calculate the speed and tell the eyes how rapid to move, left or right, up and down, where to move and how to move. So it's a very complex situation. It's not, when strokes are involved, it can make it a lot more difficult, but therapy can be beneficial. I wanted to talk about using an assistive device. So I've got Tommy right here. Now, this is a pretty common device you'll see, especially in assisted livings. You'll see a rollator. And typically, what you want to do, Tommy, if you can stand up right, I'm going to lock the brakes. I'm going to say, here's how you get up. Now, typically how people get up, let me just show you how they typically get up. They usually are going to start grabbing for this walker, and they're going to start reaching for it. Put both hands up here. They're going to start grabbing and trying to pull themselves up. And that's not how you do it. We're going to go through the steps. You get the walker in position. You have the person scoot to the edge of the chair. And the reason is They need to be able to get their feet as near to their center of balance as possible, so when they transition from sitting to standing, they're already over their feet, they're balanced. Typically, what people will do, you'll see them trying to throw themselves up and fall back, and throw themselves up and then fall back. So if you're here and you got your feet back, that's what we're going to cue. We get your walker set, you lock the brakes, you put your hands, if you have armrests, you put your hands on the device, on this chair you're coming up from. All right, coming up, rise to stand, take one hand at a time, place it here, then you place the next hand up, and then you're steady. And sitting down is reverse of that. You go back, both legs touch, you reach back with one hand to make sure you know where you're going, and then you ease back slowly and have a seat. And one thing you can do, if you've got somebody who's dropping a lot, you want to cue them, stand back up for me. When they're going to have a seat, you just stand right beside them. This is what therapists are going to do. They're not going to help pull them up. What you want to do, say, all right, come on back, have a seat, reach back with one hand, and as they're sitting down, they're going to tend to want to lean back and fall. Don't let them. Keep pressure. Come on, have a seat. Keep pressure on their upper back and make them lean forward so that they fold down and go slow. And what you're going to do is you're going to make them activate their quads and activate their glutes, and you're going to start the strengthening process in an eccentric contraction as you're lowering. So we're always trying to teach people, go down slow, because that's actually a strengthening situation for you. It'll make you stronger and make getting up easier. So scooting to the edge of the chair, feet back, push up with both arms, and then one at a time. Good. Now, when they've got the shoes on that they normally wear, you look at the assistive device, you pull it back, and you look to see where the top of the device, whether it's a cane or a walker, we can see this is too short because it should come, these two bumps on the sides of your arm where your bones are, that's the height that you want the arm. So we would elevate this. So for Tommy, we would raise these up, we would loosen this, we'd raise it up until, stand up tall and straight for me, until it came right here. And the reason for that is, when he extends his arm and has it like, have a little bit of bend in the elbow so that he can extend it forward without leaning forward. And it'll maintain better posture that way. But you always want to make sure before you adjust in a device, whether it's a cane or a walker or whatever, you want to make sure they've got the shoes on that they're going to wear. They stand up tall and straight, and then you adjust it to the height where the top of that is coming right here, so it would meet right there. That's how you adjust it and get the right height. Now, there's situations where you might go a little higher, a little lower, depending on the individual. But for the most part, that's going to get it about 95% of the time and put it right on target. All right, Tommy, you can have a seat. Whether or not you use a rollator or a walker, that's something a therapist will talk to you about, depending on that person's ability. As we get advanced in Parkinson's, you'll see somebody trying to use a rollator. It really can get away from them quick. And sometimes it's hard to manipulate a device. So it just depends on where they are. Really, a therapist can assess that person and determine what's the safest. But generally, the rule of thumb is if you can walk without a device, you can walk safely, then you don't need a device. If you can walk safely with a cane, then a cane's appropriate for you. If you can't walk safely with a cane, then you need a walker. And it kind of goes like that. So you're going to it's a progressive thing to see what level can you safely maintain your balance. And what you'll see is the rollator has a lot of advantages. It's got large wheels, it's got brakes on it, it rolls very easily. So someone who is still at a pretty high level of mobility, but just needs a little steadiness and also an ability to sit. If they lock their brakes and they get short of breath, they get fatigued really easily, they can lock their brakes, and it's designed to have a place where they can sit and catch their breath and rest. You will see people try to use it as a wheelchair and scoot around. Don't ever do that. It's not a wheelchair. It will turn over on you. You've got to make sure the brakes are locked and then you can sit.
I have a question.
Please.
So, as families are walking through an Alzheimer's and a dementia situation, Tommy, do y'all ever need to reach out or you reach out to your team for the slums or the MMSA test? Do y'all administer that?
That is the test for memory, correct?
Correct.
Yeah, so we have a test, it's called the MOCA, and a speech therapist, which Joe mentioned, the 360 memory care. A speech therapist will sit down and do a MOCA test and see what grade they are, there's a grade between, I believe it's 6 and 26. They fall between that grade, they qualify for speech therapy with our team for at least 4 months. We'll come out there for 4 months and do some training, some memory exercises on the tablet. So the speech therapists will come out twice a week with that person, that patient, and make sure we're getting their exercises in their brain to keep up with their, any kind of memory dysfunction that they have, that we can help out and help exercise and get better.
I know also there are times that you are in the home and working with these families, and you can see the caregiver burnout, or families are saying, I have to get back to work. And they're starting to ask about, what do we do next? And they're starting to ask about assisted livings or memory care situations. How do you address that? And then the second part is their concerns that if they did have to move their loved one in, then they give up home health. How do you address those?
Okay, so the question was, if I'm not mistaken, is if they get to the end of our services and they need more care and the caregiver is burned out, there is places like Your Life. I'll get a consult set up with Susie. They'll come out to the home, talk to the family, and discuss what kind of care they provide at the facility. So then once that goes, hopefully they'll get into the Your Life. They'll sit here, so now the caregiver gets a break. We continue therapy here as they leave from their home setting to Your Life. Our therapy team can still come to Your Life and keep the continued therapy going. So there's no decline in care. Their stamina, their strength, everything's still gonna be on an incline. So there's no question that we can follow them from their home to a facility. Is there another question to that?
No, that was it. Thank you.
Okay, so yeah, we can definitely keep the exercise going and strengthening going. As long as there's a good picture to paint, we'll continue.
Yeah. One of the things we talk
We have what's called a case conference, where we sit around a table, kind of like in here. We sit around a table with all of our nurses and therapists, and we discuss different patients, things that they need, or where they're having difficulties and how we can intervene. And one of the key things we say all the time is we're making sure that they have the right level of care at the right time. And so there's a right level for every type of situation. And so it's what you'll find in the community. There's assisted living, there's nursing homes, and people get these things all confused. And so it's nice to have a caregiver to help guide you and direct you through to say, no, that's a big difference. Assisted living is very high level and a wonderful environment to be in. We come out here and it's just fantastic. And so they get the support they need. They're having difficulty cooking in the home. This is the little things they're having trouble with, or maybe some memory starting to slip. They're having that early onset of dementia. And so these transitional pieces are fantastic now that we didn't have 20, 30 years ago. We didn't think about. And it makes things a lot better. We come out to the home care and try to establish it in the home environment, but we do have those discussions to say, hey, this is what's available in the community to help that transition when we know that caregivers are at a point where it's becoming difficult, or the family themselves say, hey, I want to maintain the highest quality of life I can and independence. And one of the great things is to go into assisted living, but I don't want to cook anymore. I can't do that. It's just a burden to get groceries. You go to assisted living and they're going to help you, with that part of it, while you can at the same time be still involved in the community and go do things, very much so, and still have a great quality, maybe a much better quality of life, because you develop a lot of friendships and things like that. So it's actually, we see people get really isolated and depressed. That's one of the things we'll talk to them about, is have you considered being a part of a community? Because we're designed and created to be communal, and the worst thing that can happen to an individual is to place them in a situation of isolation. And so it's wonderful to have that, and nursing and all that stuff can still happen in this facility from home health care and all that.
So another question that I have for Tommy, and we do get this a lot. So we have a resident here, and they have decided that for choice sake, because there's choices for home health, but they've decided to use STEP in this case. And they come on, they are on service for several months, and they're doing so well, they graduate. Then, about 3 weeks later, there's maybe an issue going on, maybe mentally, or possibly there's a UTI, and the physician changes a medication. that has now affected their balance or their walking or their neurological situation. Tommy, what could happen at that point? Are they just stuck because y'all got rid of them on home health, or are there still options?
There are options. So insurance, again, Joe mentioned insurance covers it 100%. We do a frequency, so say twice a week for 3 months. As soon as we discharge on that third month, because they graduated, they pretty much met all their goals, we discharge this month, and say 3 weeks later, a month later, they change medications, they have a fall, they injure themselves. We can get right back out there. As soon as we get an order from a nurse practitioner or a doctor, we get right back out there and start that therapy twice a week, sometimes 3 times a week, just depends on what the therapist sees. So no, there's no problem with the insurance. As soon as we get that order, we'll get right back out here, continue therapy. And nurses will also come out to kind of correlate with the nurse practitioner or the doctor and see what kind of medications have switched, so we can kind of just put our heads together, make sure they do have the best medication, best care, best therapy, and best team involved for that patient and resident.
Thank you, Tommy. We do get that question a lot, don't we?
Is that right? That's interesting. Well, one of the things STAT does do is we have what's called a Carpenter Health for Life, and it's our parent company is Carpenter Health. And one of the things they do is when we have a patient, we keep up with after discharge. We call them frequently just to check on them. How are you doing? A lot of these people, they're elderly, living in their home alone. They may not have family to check on them. So we find that's one of the critical factors is following up to see how are you doing. And if we need to just do a stop by to check on them, we do that. But for the most part, if we find out they're having a problem, like you said, urinary tract infection, sometimes when that happens from time to time, we get them on the phone and say, I'm having a lot of trouble right now, and I've had a fall the other day, I don't know what to do. And then we'll help guide them to get a hold of their physician and get out there so we can go check on them. And if it's something that we can correct very quickly, then we'll be in there just very quickly. If it's, hey, this is going to be a little more involved, there's a lot more going on here, then we're going to be in there. It's whatever they need to take care of that situation and make sure they're taken care of.
And that leads to another point, Tommy, I want to address you with, because you're out in the community. So if you go into a home, or your team does, and they realize that this particular patient wasn't so demented, but they're to the point that they can't drive, they don't have food in the home, maybe there's transportation, how do you engage with additional services like council on aging or whoever? Do y'all work to assist to get those services needed?
Yes, so there is a lot of resources out there. What we would ask for is a social worker order. So a social worker that works for us will go out to the home and check out all the outside resources, like a counseling on aging, or some people like sitter services, what they call, but there's more of I'm not sure another word for them, but we call them sitter services, which they come out, help aid, and that is not covered by insurance. It is private pay, so there's about 4 or 5 of them in this area. They can get the contacts online, and they'll give you a pricing. They'll come out and do like the laundry, the cooking, help with medications, folding clothes, just kind of be there from 4 to 8 hours a day. And again, like you said earlier, the caregiver gets burned out, so they just need a break for a 4-hour day to get out and about. They can hire that sitter service to come in and sit with their loved one and take care of them for any needs. And then another resource we can find out is helping get them into a facility. It's called assisted living locators. They come out and they know all about the area, they know about all the ALS in this town, so they can also help transition your loved one into the facility.
So y'all really do so much more taking care of your patients other than just the therapy options. You go above and beyond to bring in that social worker for those community needs. I absolutely love that. And one last question. Do y'all ever utilize the, what was it called? The sit to stand or the walk to stand? It's where you stand and you walk so many feet, like it's supposed to be so many seconds. I don't remember the name of that. But is that one of the tools you use?
That's one of the ones. We use Compositonetti. There's an up and go. There's a timed up and go.
Up and go, yes.
Yeah. Therapists use a lot of these different ones. There's Romberg tests. There's all different types of things we'll use depending on, because you like to have a lot of objective tests so you can see this is where we are, here's where we want to go, we believe you have the potential to get here, and then you can track the progress and try to find some objective tools, some things that you can measure progress with. And so that's one of the key things we like to do. And we use tests like that to see how well you're getting up and down, how well you can do, like, just like we're talking about with the standing balance, eyes open, eyes closed, arms crossed, and we look at, different things like that to test where are the deficits, in your, balance center. So, is it visual, is it vestibular, in the inner ear, or is it, somatosensory? Is it the sensation in your
feet and things like that. So we'll do a lot of different.
testing and special tests that measure your ability to walk and your ability to transition and get up, as well as manual muscle testing and things like that.
Fantastic. Do we have any questions coming through on Facebook Live?
No, we just have lots of great jobs. Hey Joe, hey Tommy.
Oh, very good. Very good. Well, we know that this has been super educational. It is our pleasure to partner with Joe and Tommy and allow Scott to come in to give us this educational piece. We try to constantly bring different companies in, different community organizations every quarter. We don't like to have the same topic over and over. I trust, though, that if you've got any questions, comments, concerns about home health or about memory care, you can contact me directly at 850-417-1260. Or if they wanted to go into additional detail, Tommy, could they contact you directly?
Yes, my cell phone is 850-382-4333, and that's my cell phone. Call anytime.
And Joe, you are in y'all's office most of the time as the executive director?
Yeah, and get out on the weekends. I'll do a weekend rotation just to make sure I'm still doing things and keep up with what's going on.
And how could they contact you in the office?
Just call our main number, and going through Tommy's the easiest way, but call the main number for the office. And let me just say, I just want to tell you thank you for inviting us. We are just very thankful. Good Lord's given us the opportunity to serve this community in conjunction with our partners like Your Life. It's a wonderful place, and we just appreciate you inviting us out here.
Yes, absolutely. Y'all have an amazing night. Don't forget, tune in tomorrow at 10 a.m. for our COVID update, our amazing engagement update, our food update, and you never know what kind of day it is. There is a special day tomorrow, and I already know what it is, but I'm not going to tell you, and neither is Kim. We will wait to see you there. Good night.